Welcome to The Spine Guy. I'm Dr. Brian Su, a fellowship-trained spine surgeon in Marin, California. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. I'll be posting videos weekly, so don't forget to hit the subscribe button to catch them as they come out. There's a couple different ways to treat disc herniations. Typically, 90 to 95% of patients that present with a disc herniation never need surgery. And the body's ability to heal a disc herniation is one of the most amazing things about the human body, I think. The amazing thing about it is this nucleus is immunoprivileged. Essentially what that means is the nucleus developed out of something called the notochord. All that really means is when you're in your mother's stomach and just 2 to 3 weeks old, what happens is this very primitive structure, it's a very, very thin, fine structure called the notochord. As you develop in utero and develop, the entire body develops, and the one residual portion of that notochord is the nucleus. Which means that your body's immune system developed after the nucleus. The nucleus pulposus in the lumbar spine, or in the entire spine, is one of the most primitive structures in the body. It's so primitive, it's a foreign object, if you will. This means that if the donut layer tears and the jelly spits out, like so, the body knows that that jelly shouldn't be there. So what ends up happening is the body sends white blood cells that will come and consume the jelly. And after the body consumes the jelly, the body will heal the outer annulus. I can't tell you how many patients I see that say the jelly actually sucks back into the jelly donut, or that once the jelly's out, it's always out, or the jelly can reconstitute itself. The treatment of all disc herniations is based on the strategy of buying the body enough time so that the body can heal itself. 90 to 95% of these just heal themselves. This is a great example of a disc that's resorbed over time. This is a patient who presented to me. He's only around 25 years old. This is the side view of the sagittal. So there's the back, butt, belly, L5-S1 disc. There's a donut layer tear, and there's a disc that's kind of squeezed out, hitting the nerve. This is a pretty big disc herniation. This is the cross section. So this is the axial view. There's a cross section of L5-S1, and this entire thing is jelly that's in the spinal canal hitting the nerves. This patient got 2 epidural steroid injections, physical therapy, and in fact, nothing was done other than conservative care. And this is him 6 months later. So you can see we didn't do surgery on him, but over time what happened is the little white blood cells came and knows that this jelly shouldn't be there, and it flattened it and consumed that jelly. And you can see the same thing on cross section of how much of that disc disappeared. So that's just a great representation of the body trying to heal itself. There's a couple of different ways to calm the nerve down so that the leg pain can be tolerable, allowing the body to heal itself. So the first is just an anti-inflammatory medicine. If you start getting buttock and leg pain, immediately start taking an anti-inflammatory. The biggest mistake people make with anti-inflammatories is they don't take them chronically. Many people get leg pain or even back pain. They take 2 ibuprofen, their pain gets a little bit better, they stop taking it, and they take it again. What you need to do is build a baseline level anti-inflammatory in your blood. For an adult male, typically 800 milligrams 3 times a day for 14 days. For women, usually 600 milligrams 3 times a day for 14 days. The key is to take it 14 days straight, 3 times a day. Even if you don't have pain, you take the medicine, and that's because once you take the medicine, you build a basal level in your blood and it maintains that level. Taking ibuprofen once in a while for acute inflammation is not as useful. So that's the first thing I would recommend. The other thing that may be helpful is a nerve medicine called Neurontin. Neurontin is the same name as gabapentin, and if you go online and read about Neurontin, you'll see that there are all these crazy side effects. What I typically do is start my patients on a very, very low dose, which is just a test dose. The best I can say is Neurontin can sometimes make people feel goofy. So we start 200 milligrams twice a day, and this is a drug you take every day while you first have leg pain. Then 400, then 600, then 800 twice a day. Neurontin can go up to pretty high doses. Other possible medications include muscle relaxants such as Flexeril and Baclofen, and obviously narcotics. Narcotics tend not to touch nerve pain as much, but can certainly be an option when your pain is horrible. I would ask you to consult your spine doctor for advice on use of any of those medications. One of the best things we can do for a disc herniation to try to calm the nerve down is a steroid. Steroids can be administered in two different ways. The first way is an oral steroid. It's called prednisone. Prednisone, typically, think of it as a very, very strong ibuprofen. It needs to start, however, at a high dose, and you taper it down. I typically use 60 milligrams, 50, 40, 30, 20, 10 over a 7 or 6 day period. And what that allows is the anti-inflammatory to hit the nerve and take the inflammation off the nerve. What can sometimes happen is the pain is from two things. The pain is, one, from the herniation physically pushing on a nerve that's next to it. But also, as I told you, the nucleus pulposus, because it's foreign to the body, incites a very, very strong inflammatory response. In fact, they do these animal experiments when they can suck a little bit of chemical out of an intact nucleus, then drip it over a mouse's nerve, and even though there's not physical compression of nerve, there's tremendous inflammation. So just the fact that the nucleus is out in the open makes it very, very inflammatory. The other way to deliver steroids other than oral steroids is an epidural steroid injection. Epidural steroid injections is one of the mainstays of treatment for disc herniation and can be very, very effective. Epidural steroid injections have gotten a bad name because they're sometimes overused. In general, I wouldn't recommend more than 2 injections for a lumbar disc herniation. If you're getting more than 2 injections, you either live with the pain or have it fixed. An epidural injection essentially involves going into a surgery center typically, and the epidural injection is sometimes done by spine surgeons, but usually by pain anesthesia doctors or by a physiatrist. But an epidural steroid injection is essentially the doctor taking a needle and targeting over the nerve, injecting a little bit of steroid, and the steroid calms the nerve down. It does nothing for the disc herniation. Remember, the only thing that can take that disc herniation away is the body slowly healing itself with white blood cells or surgery, which is what I do. The epidural steroid injection is typically an outpatient procedure. It takes about 20 minutes. Usually we tell patients not to work that day, but they can work after that, and to try to stay laying low for 1 or 2 weeks because you want the medicine to stay around that area. Epidural steroid injections can sometimes be very effective immediately, meaning within the first couple of hours, because sometimes there's local anesthetic. But an important thing to remember about epidural steroid injections is that it can take up to 2 weeks to work. And sometimes the pain can even be worse in the first couple of days. Do not lose hope if you get the epidural and it hasn't helped in 10 days. I would wait the full 14 days. So one of 2 things happen with an epidural steroid injection for disc herniation. We do the epidural steroid injection, the pain improves, and maybe that's all that happens because we bought the body enough time, and as the nerve was not inflamed, the body slowly sent white blood cells to munch up that jelly. The second thing is the nerve can come back because that steroid can wear off, but if that disc herniation is still there because the body hasn't healed itself, which happens in 5 to 10% of the time, then that nerve will still be upset. You'll still have the sciatica. So you can, again, do another steroid injection for up to 2 injections. And after that, there are 2 options. One, it is totally fine to live with the pain. There's absolutely no necessity to get an operation for disc herniation if you have reasonably good strength and the pain is tolerable. The pain is not an indication something bad is happening to the nerve, and a decision to do something surgically about it for a disc herniation is totally about quality of life. I have many patients that come in to see me that say, I have a disc herniation, I have some leg pain, I can live with it, I can do the things I want to do. Yeah, it's a little bit annoying, but I can live with it. Do I have to take it off the nerve? Absolutely not. You absolutely do not have to get an operation for a disc herniation. However, if your quality of life is limited, so we measure quality of life in 2 different ways. I tell patients this all the time: physical and emotional. Nerve pain causes limitation in physical quality of life. You can't do the things you want to do. For example, play tennis, go golfing, go traveling, hang out with family members. It physically limits you from doing the things you want to do. And it can cause emotional distress. Nerve pain can cause depression, downheartedness, mood changes, irritability. If you're finding that you are having changes in quality of life physically and also emotionally, then you're a good surgical candidate. Typically, the rule is we wait at least 6 weeks from the onset of buttock and leg pain before even recommending surgery. And that's because 90 to 95% of these do get better over time. There are 2 different caveats here when I said that you don't necessarily have to have surgery for a disc herniation. There's one syndrome called cauda equina syndrome that I would caution you, go to the ER if you develop these symptoms. Sometimes the disc herniation is so big, meaning the entire disc has extruded out like that, and it obliterates the entire spinal canal. The nerves that are in the lumbar spine, they go through the buttock and leg, but they also bring signals to the bowel and bladder. So there are situations when people can lose bowel bladder control. It's typically not subtle. It's loss of urinary control, it's wetting the bed, sometimes not being able to get to the bathroom on time. And often it's accompanied by a lot of leg weakness, numbness, what we call in the saddle distribution, which is kind of in the buttock and the perianal region, the testicle region, the vaginal region. When you start getting numbness there, issues with bowel bladder control, you have to go to the ER. You have 24 to 48 hours to get that pressure off of the nerve before you get permanent bowel and bladder injury. So that is a surgical emergency. That is in fact one of the only surgical emergencies aside from a dislocated spine or trauma in the lumbar spine. The other one, I wouldn't say urgency or emergency, but something to watch out for is weakness. So I just showed how to do a physical exam or motor exam of the L4, L5, and S1 nerve roots. But sometimes disc herniations are accompanied by significant weakness because, again, the signal is not getting to the muscle. So we grade weakness in a scale of 0 to 5. And the reason that's important is because depending on what grade that is how urgent something surgically has to be done. 0 is paralyzed, 5 is full strength. 3 is anti-gravity. So, for example, if this were my foot, this is 0, meaning I'm trying to do this, but I can't move it at all. That's 0. This would be a 3 where I can move it against gravity, but then it kind of falls. I can do it against gravity and falls. 5 is I can move my ankle all the way up, and when someone's pushing on it as strong as they can, I can resist as a 5. From a surgical intervention standpoint, we have pretty good data that suggests that if you have strength of a 0, 1, 2, meaning you basically have a paralyzed foot and you can't even lift it up against gravity, that surgery sooner leads to better outcomes than surgery later. It makes sense. If you take pressure off the nerve that's causing severe compression on nerve and marked weakness, meaning you can't even lift it up against gravity, then surgery is probably going to be better sooner rather than later. It doesn't mean if you do surgery later that you won't get the strength back. It's just the outcomes are better when you do the surgery sooner. How soon? We have recent literature to suggest that even within 48 hours of onset of weakness, that patients have better outcomes. Now, if your strength is a 3, meaning you can hold up against gravity, or better, then there's a little bit less urgency in that. Typically for my patients, I tell them if they're a 4 or a 3 plus, meaning they're reasonably strong and they can definitely do it against gravity, but their foot does flop a little bit when they walk with a foot drop, that we should watch the strength very carefully, but that's not a reason to jump to surgery. I get worried when strength is 0, 1, or 2. People always ask how much time has to go by before I get permanent nerve injury. For pain, there's some data that suggests that if you have more than 6 months of pain, that surgical outcomes are not as good, again, because that nerve has been compressed, there probably is some permanent nerve injury happening. In addition, if somebody has weakness, if their weakness doesn't improve over a 6-month time, and again, most disc herniations get better in the first 6 to 12 weeks, but if it's 6 months and the strength isn't better, or the strength is getting worse, we'd probably recommend surgery to try to recover some of that strength. I usually encourage my patients to have trace weakness, which is probably 90% of my patients, to just kind of wait and not have surgery right away. So let's say you failed 2 epidural steroid injections. You've done things to avoid surgery like physical therapy, acupuncture, sometimes even gentle chiropractic care. You've done the medications and you still have 8, 9, 10 out of 10 buttock and leg pain. clearly that's interfering with quality of life, then surgery is a great option. The surgery is called a microdiscectomy. Sometimes it's called a minimally invasive microdiscectomy. It's one of the most common surgeries that's done in the United States. It has outstanding outcomes. In general, a microdiscectomy is better for treating buttock and leg pain because you're addressing the problem, you're taking the pressure off the nerve, which is causing leg pain, than back pain. Patients with more back pain than leg pain tend not to do as well with surgery because back pain is usually multifactorial. Back pain can come from arthritis, muscle strains, degenerative discs. There is a component of back pain to disc herniations, but really disc herniations cause buttock and leg pain. And it's really important to differentiate the buttock and leg from the low back. So the butt, where you sit, is actually part of the sciatic nerve because you saw earlier, the sciatic nerve comes out through the buttock. The surgery is a minimally invasive microdiscectomy. The surgery itself takes about 45 minutes to an hour. It's typically outpatient, meaning patients come to the hospital or a surgery center, they get an operation, they go home the same day. The incision is usually less than an inch. It may or may not be done through a tube or through a little mini retractor. Whatever method your surgeon prefers is totally appropriate. Both have terrific outcomes and both have very, very short recoveries. So I'm going to show you what's involved in a microdiscectomy. So you're typically put to sleep, and this is usually under general anesthesia, and then placed flat in kind of a Superman's position so that your back is accessed like so. In order to access the canal, we typically do what's called a small laminotomy, which is we take a burr and we just burr away just a small piece of the bone. If we're addressing the L5-S1 disc, this is the L5-S1 disc, a very common area to be herniated, and the disc herniation is stuck inside. We can put a little piece of Play-Doh in here to just show that the disc herniation is inside. So what we typically do is we'll take a very, very small fine burr, almost like a dental burr, and remove the bone, take some soft tissue off just to access the canal, move the nerve, and then with a very, very small tweezer instrument, take the disc off the nerve. It's important to realize that a discectomy does not mean removing the entire disc. The entire disc, for example, looks like that. The jelly spit out, we take the jelly off of the nerve, all this jelly still remains. So a microdiscectomy does not mean removing the entire disc. It's just removing that little piece of jelly that's spit out. After we remove that jelly, there's a little defect in the donut layer where that jelly came out. The real way for that donut layer to seal up and heal up is just time. And that's typically in the first 6 to 12 weeks after surgery, which is why I personally give a sitting precaution to my patients after surgery, because sitting upright, straight up and down, puts the most amount of pressure on the disc. In my patients, for the first 6 weeks, I tell them to do less than 10 minutes of sitting at a time. If they sit upright for 10 minutes, they can get up, walk around, decompress their spine, sit back down, and do less than 10 pounds of lifting. Sitting upright puts the most pressure on your disc. Reclined is okay, walking is okay, standing is okay, but sitting upright tends to be a bad position for the disc. The risks of surgery, there are some, which include the risks of general anesthesia. There is a risk of nerve injury because we're accessing the nerve, we're moving the nerve, we're retracting the nerve. That can lead to increasing weakness or pain. It almost always gets better over time. Chance of nerve injury is exceedingly small, less than 1 in 1,000 for this type of surgery. The biggest risk is probably something called a dural tear, which is a tear in the covering of the nerve. The nerves swim in fluid, and that fluid is covered by a thin sac as thin as saran wrap. If the disc or the bone spur is scarred to the sac, as we remove the disc and bone spur, the sac could tear. If the sac tears, spinal fluid leaks out, the nerve is fine. We repair it typically with a very small suture or some glue and lay the patient flat for 1 or 2 days like that on their back, because once they sit up, the spinal fluid drains. So we lay patient flat for 1 or 2 days. It delays recovery. It does not change the ultimate outcome of surgery. Chance of a dural tear in a lumbar discectomy is about 3 to 5%. After surgery, chance of infection less than 1%, and chance that anything else can happen at this vertebral level. Yes, we did the discectomy, but you can still develop bone spurs, fractures, instability, things like that. We haven't put in rods, screws, cages. We've simply taken the disc off the nerve, and that level is still a motion mobile level. The biggest complication postoperatively is something called recurrent disc herniation, and the degree to which a recurrent disc herniation occurs really has to do with the size of that defect. So if you can imagine, the defect is there, and here's a dark piece of Play-Doh. It has to seal up over time, and that place where it seals up is a little bit weaker than the rest of the outside annulus. So then more jelly can come out, and you're back to where you started. Once that annulus heals up, that disc is always susceptible, but typically at the 6 to 12 month time point, you're outside of that risk of recurrent disc herniation. From a rehab standpoint, my patients are placed in a lumbar corset for comfort, which is a soft brace. And usually for the first 2 or 3 days, there's significant back pain because of the incision. Most patients are walking into their wound check or the nurse wound check at 5 to 7 days. And at the 4 to 6 week time point, walking 1 to 2 miles at once. I'll typically start core therapy strengthening at 6 to 8 weeks and let patients go back to the gym at 3 to 4 months. So as you can see, there's lots of different ways to treat disc herniations, from non-operative, which work 90-95% of the time, medications, physical therapy, oral steroids, epidurals, and lastly surgery, which hopefully you don't need, but if you do need it, it really has terrific outcomes. Thanks for watching. Don't forget to click the like button and leave questions or feedback in the comment box below. Feel free to let me know what videos you would like to see in the future about the spine.